Okay, well, welcome back again. We're going to be talking about Learning Outcome 5.2, which is discussing the validity and reliability of diagnosis. 5.2. This is for IB psychology, and the unit of study is abnormal levels of analysis. As a review, or just to discuss quickly, in the last section we talked about 5.1. We were talking about normality versus abnormality in psychology, and we defined what normality was, we defined what abnormality was, and we looked at how using a statistical deviation from a norm to help us rely on what is normal and what is abnormal isn't necessarily the strongest way to approach looking at normal versus abnormal. We talked about how there are strong social factors within this particular learning outcome. So again, if you have questions, again, go back to the readings in this section and take a look at the standard, the SANE study, the Tyler and Brown study. I think those were the only two studies that I mentioned in that one. So let's go ahead and move on and start talking about Learning Outcome 5.2, discussing validity and reliability of diagnosis. There are three sections we're going to look at. The first of these is actually making the diagnosis. The second is how reliable or reliability of diagnosis. And the third one is the validity of diagnosis. When is a diagnosis valid? Okay, so let's go on. Okay, we're looking at diagnosis right now. What is the diagnosis and how does it work? Well, in a nutshell, diagnosis is identifying and classifying abnormal behaviors. Once we decide this is considered to be normal, 5.1, and this is considered to be abnormal, 5.2, then we can identify those things that are specific that are considered to be abnormal. Then we can classify those things. Now, classification of abnormality goes back to 5.1 again, and a text that I referred to called the DSM. The DSM is the Diagnostic Statistical Manual. DSM, I'll write it up here. And we are currently in version 5. Though the books, I think your textbooks, and most of the books that are out in publication right now, refer to DSM 4. You're not going to get any specific questions about the DSM, other than you can use it to help make your point. You don't have to be specific about it. What they look at here in identifying and classifying abnormal behaviors are primarily symptoms. Okay, what sort of symptoms is the individual presenting at the time? And we do this a few different ways. This is not inclusive, the list that I have in front of you. Well, we'll start off with self-reported. Self-reported is what the person talks about, what the person is stating at the moment. This is what I'm experiencing, self-reported. What is observed when you, the clinician, when you, the psychologist, observe this person, what are those abnormal behaviors that you're observing? Then the third one, okay, are tests. What sort of psychomotor tests can we run? What kind of assessments can we do that will help us better understand the symptoms that are being observed or self-reported? Or if there are no observations and nothing reported, but somebody has a hunch, maybe it comes out with the testing. And the last one is the family history. Is there a family history, or reported by family members is another way of looking at it. Your mother, your father report that they see you doing this. You don't see it, but they see it. You have a family history of, schizophrenia. These are the things that are important in this particular section to help us understand what's going on. All right, moving on. Okay. Okay, then the next of these is psychological testing. And the psychological testing, it can be a variety of different ways of approaching this. The third item is the DSM Volume 5, or Version 5, I should say, and a new bit of information that I have for you here, and that is the ICD 10. The ICD essentially stands for the International Classification of Diseases, and this is up to version 10. I can't remember when version 10 was issued. It is used by the World Health Organization, the WHO, the World Health Organization, not to be confused with the rock group, the WHO, who come around and very similar to the DSM, it has classifications for not only mental disorders, but physical disorders as well too, and it's a numbers code. They use a very complex numbers code, much like the Dewey Decimal System for classifying books. All right, and so this is how we work the diagnosis. The diagnosis is pretty much standardized based on either DSM for the United States, and depending who you look at in Canada, and other places use our DSM as well too. It's not just exclusive to the United States. It is an American publication. The ICD is an international classification, and we use it here in the United States as well too when we're reporting out disorders, illnesses, injuries, and so forth on an international basis. Sometimes you'll see it diagnosis/ICD code as well too. And insurance companies use these codes when they're paying out claims. The next thing we're going to get into is the reliability of diagnosis. So what I've written here for you is how reliable is a diagnosis. One, the diagnosis is based on human factors. That's the most important thing I think you need to remember here, is that when we deal with making a diagnosis, we're dealing with a human. Human beings are fallible. Everybody makes mistakes. You make mistakes. I certainly make mistakes. And in those mistakes, if we're not listening intently to what the patient is telling us, then we run a big risk of not reporting certain things. If we don't observe something and it seems to appear when they're out of sight, then we're missing something as well too. If we're not as knowledgeable in certain areas of mental health and we miss it because of a lack of personal education, then we've contributed to a misdiagnosis as well too. And that's what we have to keep in mind here. Next, the diagnosis is based on what is observed and or what is reported. Back to the early part, diagnosis itself. What does the family report? What does the individual report? What do we observe? And here I want to stress the importance of standardization, the DSM and the ICD-9. 10, I say. It's actually 10. I keep saying 9 because that's the one I last worked with on a regular basis, the ICD-9. So the importance of standardization really helps us to be able to give a person that presents himself with a standardized diagnosis. We don't have to fidget with a diagnosis one way or the other. He seems to have a little bit of this, he seems to have a little bit of that. The analogy I can give is it's kind of like a Chinese menu, the old Chinese menu. And I want one from column A and 2 from column B and nothing from column C. Pardon me. It doesn't work that way. And if you look in a copy of the DSM, you'll see that, let's just go back to depression. You know, there are periodic depressive episodes. There are full-blown episodes where they're having periods of melancholy, sleeplessness, or too much sleep, lack of activity, things of this nature, more often than not. How many days out of a month? They diagnose these things based on a preponderance. So this is really important for us to see. But this isn't the end-all, the be-all of making a standardized diagnosis. There are problems with this, okay? Here I want to talk about the Cooper study, the Cooper et al. 1972. It's in your study guide as well too. It's the reliability of diagnosis, and they were looking at schizophrenia and depression. And what they did was they took a series of videos, and people were displaying certain prescribed symptoms in these videos. You'll have to read the original study. It's been a while since I've actually read it myself. But in it, these people had, I think there were 5 or 10 videos, and they asked physicians both in the United States and in the UK to examine these videos and come up with a diagnosis. either schizophrenia or depression. Oddly enough, what they discovered was in the UK, the diagnosis of depression was twice as likely to occur versus schizophrenia. The opposite was true in the United States, where we saw the videos, the same videos they saw in the UK or vice versa. We saw those videos and we turned around and said, these videos look like schizophrenia. This person has schizophrenia. Where it was twice as likely in the United States we would diagnose them with schizophrenia as it was in the UK where they would be diagnosed with depression. And let me tell you, if you don't know anything about these, depression is definitely worse than, or not as bad as schizophrenia. I'm sorry, not as bad as schizophrenia. And I think I've said it before. Schizophrenia is a mental disorder that can really clear a room. You know, you can come in and say, I was diagnosed with depression. People kind of accept it these days. All right, it's one of those acceptable things that we talked about, obsessive compulsive disorder. If you don't have an obsessive compulsive disorder, you're not with the in crowd. And depression is kind of growing that way as well too. There's more acceptance for this type of mental disorder along with bipolar. But schizophrenia, that's just like the cancer of mental illnesses for a lot of people. They just don't know how to deal with it. And so as a result of it, it is viewed in Western cultures primarily as just being really a bad kind of a disorder. And it will really clear a room. So we were diagnosing, just to summarize one more time, in this Cooper study, we were diagnosing schizophrenia twice as often as they were in the UK. The UK was diagnosing twice as often depression in the same set of videos that were showing the same standardized symptoms. Okay. Next, moving on to the fourth section, or the last thing we're going to talk about in earnest here, is the validity of diagnosis. When we have decided what a diagnosis is going to be and how reliable that diagnosis can be, the next thing we have to do is find out if the diagnosis is valid. And here in the study guide, the validity of a diagnosis refers to receiving the correct diagnosis. Okay, it's not just the correct diagnosis, but it's the correct treatment to go with that diagnosis. When we have diagnosed the person, and we'll just use depression again, with depression, and we are treating that person with the correct medication, and that person is responding to it, then we have made a valid diagnosis of this particular problem. Sometimes, you go to a physician and you say, doc, it hurts when I do this. And of course the joke is, okay, then don't do that. But the doctor says, well, I can't really figure out anything that's really wrong with you. I'm just going to treat your symptoms and hopefully this will go away. I don't have a working diagnosis for you. And that is more often true than you think about. If you don't have a preponderance of the symptoms going on, how could you expect anybody to make a valid diagnosis? They will come up with a working diagnosis. You seem to be displaying symptoms of depression, but I am loath to label you with depression. Now, remember, mental illness, the label goes a long, long way. It kind of sticks with you for the rest of your life. So, people will say, I'm going to treat you for depression. I'm not saying you actually are clinically depressed with major depression. I'm just saying that right now and in the past, you've been displaying very strong symptoms of depression. So that is what I'm going to treat. And then we're going to follow back up with you again, and then follow back up with you, and follow back up with you, and go on from there, and see what we come up with. That is how a lot of people will go ahead and begin the process. It doesn't mean that we've come up with an invalid diagnosis. It just means we've come up with a diagnosis that we're working with at the moment. And so it refers to making correct diagnosis and providing correct treatment. That's what this section deals with. And the DSM contains only symptoms. That's what you have to understand here. There is no etiology. There is no saying. There's nothing in the DSM that will tell you the reason that this came about, the causality, etiology, the causality for this particular symptoms. They could be social in nature. They could be hereditary in nature, as we will begin broaching in the coming learning outcomes. There are a variety of different reasons they could be coming to us, a lot of which can be biologically inherited or hereditable, or they can be products of social status. Poor people seem to suffer a little bit more from mental illness than rich people. How much more? I really don't have the statistic in front of me to tell you. Being poor can be viewed as a social mental disorder, if you will, even though you're not going to see it in the DSM, but it can cause depression, it can cause OCDs, it can cause a variety of different things. It manifests itself in a variety of different ways when you have social stigmas that are strong. The last thing I want to talk about here, okay, in closing, is the Rosenhan study of 1973. That is definitely in your study guide. And that was titled On Being Sane in Insane Places. And this study was to test the reliability and validity of diagnosis in a natural setting. They wanted to see if psychiatrists could distinguish between abnormal and normal behavior. And this study is a real good study to really help you if you're having to write this particular prompt in May. 5 men and 3 women, including Rosenhan himself, which was, by the way, a bad thing for Rosenhan to do, was to participate in this study. He should have just been an observer. Was to go out and to a variety of different psychiatric hospitals and present themselves here in the United States, and to find out how many people were going to be diagnosed with various disorders. And you could read the results in your own study guide. They were admitted to various psychiatric wards, and all but one was diagnosed with schizophrenia, and the last one was diagnosed with bipolar, manic depression, bipolar disorder. They were all healthy. That's the odd thing. They were all healthy. And so you could read this study. It's a real good study. There are some flaws. Ecologically, is it valid? I'll leave that up to you to decide. I'm not going to spoon feed you on that one. Just let's go back one more time, that this particular learning outcome begins with the word discuss, which is a level 3 command term. So this is one that kind of appears quite often in the May exam for the second day exams, because it will require a full 5 to 7 paragraph response. So know how to respond to it. And I think the strongest studies here are the Cooper study, the Rosenhan study. There is also a Fernando study of 91 that talks about the diagnosis is a social process and it is not objective. That has some flaws in the study itself. That's why I didn't mention it in the main text of today's lesson. Next time we're together, we'll talk about 5.3, discussing cultural and ethical considerations in diagnosis. And here we go into more of a social cultural aspect of this study, of this particular learning outcome. And then 5.4 is a level 1 that's describes symptoms and prevalence of 2 disorders. And here we begin looking at anxiety disorder, affective disorder, or eating disorder. And this is where we look at bulimia and major depression. Remember, in abnormal psychology, so you're not getting too confused, we're going to focus just on eating disorder, bulimia, nervosa, and major depression. Okay? Even though there are a lot of abnormal things out there, you don't have time to master them all before your May exam. Okay? All right. Signing off.